This is a courtesy announcement that this meeting is now being streamed live on the internet.
Good morning, Akila. Would you like to do a mic check?
Good morning.
Thank you. Vice Chairperson Lee, would you like to do a mic check?
Yes, good morning.
Good morning. We can hear you. Thank you. Have a great meeting.
Thank you.
Hi there, Marty. Would you like to do a mic check?
Yes, good morning or afternoon here.
Yes, we can hear you. Thank you.
Thank you.
Good morning, Pike. Tom, would you like to do a mic check?
Yes, hi, this is Tom.
Hi, Tom. We can hear you. Thank you.
Thank you.
Good morning, Steve. Good morning, Steve. Would you like to do a mic check?
I'd rather not, thank you.
We can hear you. Thank you.
Thank you.
Good morning, Bert. Would you like to do a mic check?
Yes, good morning. Can you hear me?
Yes, we sure can. Have a great meeting.
All right, thank you.
Good morning, Chairperson Simidian.
Good morning. Is this the clerk's office?
It is, sir. Your clerk today would be Dave.
All right. Well,
Recording
I'm ready.
in progress.
I am ready to go. Is my colleague, Mr. Lee, with us yet?
He sure
Yes, sir.
is.
Yes.
All right, he was ahead of me. Good for him. Why don't we go ahead and call the meeting to order then?
Okay. Good morning, Vice Chairperson Lee,
Present.
Chairperson Simidian.
Present.
Thank you. You have a quorum.
Thank you. Thank you to the clerk's office for establishing the presence of a quorum. That means our meeting has been called to order, and that takes us to item number 2, which is the public comment period for our agenda. Public comment is that portion of our agenda set aside for comment by members of the public who wish to comment on items that are not agendized, meaning not on today's agenda, but that are properly within the jurisdiction of our committee. So let me check with the clerk and see if we have anyone who would like to speak under public comment today.
We do have a request to speak, Mr. Chair. How long would you like to give them?
3 minutes, please.
All right, one moment, please, while we get the timer up.
Thank you very much.
Our next speaker is B. Beekman. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking.
Hi, Blair Beekman here. Thank you for the meeting today and for allowing 3 minutes of public comment. Thank you. I had 2 items I wanted to ask about and mention. One, I'm very sorry about the events of the VTA last week. There may be some national security issues why they have completely suspended light rail and bus bridge service at this time. I hope we can all work to try to get back some sort of light rail service in the next week because people really need it, and good luck how we can do that. I mainly wanted to mention that I've been very impressed by the work of Kamala Harris, who she attended UN meetings about a month ago, and she really wanted to work on the ideas of openness and accountability for the future of COVID issues. And to really, she wanted to work to make sure this sort of pandemic doesn't happen again, basically. And you know, since then, in the past few weeks, it's been starting to be asked about what can be accountability of how COVID really initiated and started. That takes a lot of guts and a lot of, boy, if we could really do that, congratulations to people to do that. I think we have to take a very important understanding and position in how to work on this issue, that it isn't just a Chinese issue. It isn't just an issue of China. There is a lot of American US involvement in this process. There's a lot of WHO involvement. There's a lot of UN involvement. A lot of parties were around this subject, and the laboratories in Wuhan, China, the laboratories in Fort Detrick, Maryland. This is not just an issue about China, and we have to learn to talk about it in those terms and make this a multilateral problem, an issue that arose. And if we take that sort of tact and we all accept blame and we all learn from the experience together, that's how we build ourselves together in the future. And it's that truthfulness that we work towards at this time that I think is just can help everyone, and it help, you know, the January 6th Capitol riots. If we are clear with them and explain to them these sort of truths, and with these heartfelt good practices, that's how we relieve the tension of that situation, and the tension of, say, the VTA shooter, who doesn't feel, you know, who we can give him some sort of trust that we're working towards our better practices and better future. And I hope we can do this together, and good luck in what the work and efforts we can do. Thank you.
That concludes our public speakers.
Thank you very much, Mr. Clerk. That takes us to item number 3, which is to approve the consent calendar and changes to the task force agenda, if any. And we have only one item today on our consent calendar, and that's the minutes. So if we can get a motion by Supervisor Lee to approve the consent calendar, I would gladly second it.
Thank you. So moved to approve the consent calendar.
All right, then I will second it. Mr. Clerk, I'm assuming we have no speakers on this item, but I want to double check with you.
You are correct, sir. We have no speakers.
All right, please call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simidian.
Aye, thank you
Thank
very much. That takes us to item number 4, which is verbal reports from the chair and the vice chair relating to items today. I have none. Let me ask if our vice chair does. Supervisor Lee?
No, I don't have any additional comments other than, of course, the condolences on the tragedies that happened last week, and really thinking of all those who perished last week. And there's so much more we need to do to keep our county safe, and really thinking of this past weekend. Thank you.
Thank you, Supervisor. That takes us to item number 5, which is the report from the Office of the County Executive relating to items of interest to the task force. So let me turn to Dr. Smith and see if either he or his staff have any introductory remarks at this time.
Yes, Supervisor Danielle Christian will head this up.
Thank you. Ms. Christian, we go to you.
Yes, good morning. Danielle Christian, Legislative Manager. I wanted to provide a brief follow-up report to one of the items that was on your April agenda, and that was the referral related to federal hate crime legislation. At the direction of the task force and the board and Supervisor Lee, we did send a letter to our House delegation in support of some federal hate crime bills that were being considered. On May 20th, President Bush signed into law the COVID-19 Hate Crimes Act, which addresses hate crimes throughout the COVID-19 pandemic, with particular emphasis on the increase in violence against Asian Americans. This bill was introduced in March by Representative Grace Meng from New York and Senator Mazie Hirono from Hawaii. The act has 5 main provisions. It requires a designated officer or employee of the Department of Justice to facilitate the expedited review of hate crimes and reports of hate crimes. The Department of Justice must also issue guidance for state, local, and tribal law enforcement agencies on establishing online hate crime reporting processes, collecting data disaggregated by protected characteristics such as race or national origin, and also expanding education campaigns. The third provision is that the Department of Justice and the Department of Health and Human Services must issue guidance aimed at raising awareness of hate crimes during the COVID-19 pandemic. The bill also establishes grants for states to create state-run hate crime reporting hotlines. It also authorizes grants for states and local governments to implement the National Incident-Based Reporting System and to conduct law enforcement activities or crime reduction programs to prevent, address, or respond to hate crimes. And lastly, in the case of an individual convicted of a hate crime offense and placed on supervised release, the bill allows a court to order that the individual participate in educational classes or community service as a condition of supervised release. So these are some broad highlights of the bill that was signed into law, and I do plan to follow up with a written report with a little bit more detail that will be provided to all of the board offices. With that, I'm happy to answer questions.
Thank you. Very helpful. And let me turn to Supervisor Lee, see if he has any questions.
Thank you, Danielle, for the verbal report, and I'm really looking forward to see the written one coming through. This is certainly a very monumental legislation, because hate crimes acts actually have not been able to pass Congress for literally many, many years. And the fact that this is also a bipartisan legislation, which of course we don't see too often these days in our Congress. So I think it's so crucial that this is something that A, got passed, and B, of course, as always asked, Dr. Smith has known, is there any money we can get out of it to do better for ourselves here from the federal government? So those are the things that I certainly would like to follow up on in your written report, to make sure that we are implementing a lot of these really important changes and ideas to help protect our community. For example, like funding to do hotlines and whatnot for reporting hate crimes and the like. So thank you very much for the report. I just want to say this is something so important, especially in our county, of the large amount of our minorities living here in a diverse community. So thank you so much for that.
Thank you. All right, Ms. Christian, anything else under this item?
I'm sorry, I was having a hard time getting unmuted. No, thank you very much, Chairperson.
Thank you. All right, that takes us then to item number 6. And by the way, I'm going to rely on our clerk staff to let me know if there are speakers on an item. So please feel free to just speak up. I don't want to overlook anyone, obviously.
Mr. Chair, I'm going to do just that then. We do have a speaker for item number 5.
Great. Let's go ahead and hear from that speaker, and let's set aside 2 minutes
Okay.
for that. Thank you.
One moment, please, while we get the timer set for 2 minutes. Our next speaker is B. Beekman. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, thank you, Blair Beekman. I'll try to keep it short. As part of my public comment with this previous item you just spoke about, to have mental health counseling and good mental health skills. I'm hopeful what we can work towards as a community at this time. And the city of San Jose, where I'm from, they're having a few more counseling sessions, just community support groups on the subject. And, we have to kind of change our thinking a bit and reconsider what we think of, say, the Asian community and perhaps the elderly community, to address issues of violence and how there seem to be some sort of concept of easy prey, but it questions what we're thinking as a community, and we're doing that now. And so thank you. And it's all of these efforts, I think, that we're working on serious issues of healing right now. So thank you.
And that
Thank
concludes
you.
our public speakers.
Thank you to the clerk's office as well. Thank you to our speaker. And that takes us now to item number 6, which is a report from the Office of County Counsel relating to items of interest to the task force. Mr. Press, I believe you're teed up to handle this today.
Yes, good morning, Chairperson Sumitian and Vice Chairperson Lee. Douglas Press, Office of the County Counsel. Just wanted to make a few observations about our chart that we include for each meeting. This chart, of course, is a list of all the cases that the Office of the County Counsel is monitoring. And as you might note, it's about half the size of what it was at the start of the year. And in turn, hopefully today, my remarks will be only half the usual time, but we will have to see. But the salient takeaway today that I'd like to leave you with is that this chart is not going away, but evolving. And let me explain. So specifically, as you know, many of the, I would say with one or two exceptions, nearly all of the matters that are in this chart that we are monitoring and that have been in the chart over the past several years have been comprised largely of 3 types of activities: federal policy changes, usually out of the executive branch administration, the president's office, or related offices, executive orders, or new federal rules. Now, because these are all nearly exclusively federal executive actions rather than, for example, federal statutes, like with any incoming administration, the Biden administration has been able to undo, revoke, or withdraw many of these actions on its own without any need for congressional action. And in addition, because what we are monitoring are largely lawsuits, in many cases where there are orders that were issued against the prior federal administration. As you might note in the chart, the Biden administration has secured stays or otherwise asked courts to hold those cases in abeyance while the Biden administration reassesses its federal position. So there's quite a few of those actually where either the Biden administration has gone ahead and made its decision that it's changing course and has actually sought to dismiss the appeals, for example, in the public charge rule, but many, many others are still being assessed. The issue that I really wanted to focus on today, though, was 2 new developments sort of on the horizon that may be of interest to the county and this task force, and in turn may ultimately cause this chart to increase in the number of pages over time. And let me explain. So first, the first type of development is one that we discussed last time, which is that, and let me just turn to what's called the Health and Human Services Sunset Rule. This is on page 10 of your packet. This was an action where, stepping back for a minute, it's the county, along with a few other litigants, suing the Biden administration. And while on the one hand, that may sound like a curious development, as we discussed last time, this concerns a rule that the Biden administration, I would say an 11th hour rule, that the Biden administration inherited from the previous administration, where on literally the last full day of the Trump administration, his administration promulgated this sunset rule, which in essence puts an expiration date on nearly 18,000 health and human services federal regulations that they expire unless the federal agencies are able to do these extraordinarily onerous reviews of each and every rule. So we actually sued the Biden administration in order to challenge that rule. And in turn, the Biden administration, at minimum, at least right now, has delayed the effective date of the sunset rule until March of 2022, which should be sufficient time for the Biden folks to figure out what they'd like to do with this rule, whether it's to seek to repeal it, amend it, or somehow address it through litigation. So being that there were not that many of these sort of 11th hour developments, I suspect that this type of category of us seeking to sue or actually suing the Biden administration, at least right now, might be few in number. The second, and frankly more concerning development, has manifested in what I can only describe as a role reversal, in that there are, shall we say, some less progressive jurisdictions around the country who have begun suing the Biden administration over the Biden's executive branch actions, much in the same way that we have done over the preceding 4 years. And quite frankly, many of the arguments and angles by which they are challenging some of these Biden administration actions are the precise ways or arguments that we've used in the past. So just turning to on packet, let's see here. So, well, let me just focus on two of them in the packet. First, on page 39, I'll just turn to that right now. This is regarding asylum seekers. You may note that on the Biden administration's first full day in office, they suspended I think that's called the Remain in Mexico policy regarding asylum seekers. Actually, yesterday, the Biden administration formally terminated that program. But based on that literal day one action, Texas and Missouri have filed a lawsuit challenging that federal action under the Administrative Procedure Act and the Take Care Clause of the US Constitution. Again, many of the same bases that we've relied on in the past to sue the previous federal administration's actions. So that is, that case literally just launched, and Texas and Missouri are seeking a preliminary injunction, and briefing is underway. The second action appears on, or series of actions, I should say, appears on page 48 of the packet. And this relates to an executive order that President Biden issued also on his first day in office. This is Executive Order number 13990 that relates to climate change. And among many other things, it requires federal agencies to assess the social cost of carbon in its review of a number of federal agency actions. So that has now spawned 2 lawsuits, one led by Missouri and a number of other states, and then a second lawsuit filed by Louisiana. So that's 3 new lawsuits based upon President Biden's actions on his first day in office. So it seems likely that we are probably going to see more cases of this sort. And we, of course, as a county will have to assess to what extent we wish to weigh in on or become involved in some of these matters, but certainly we will be watching them. So again, I would say for the remainder of this year, perhaps even next, watch for the chart that we provide for these task force meetings to probably evolve significantly, but probably still remain around the same size, if not grow. So that is my presentation for today. If there's any specific questions I can answer.
Thank you, Mr. Press. Before I turn to Supervisor Lee, the one question I wanted to ask is, if we do weigh in on some of these cases, as you indicated, might be wise, that would take what form, or what are the range of possibilities in terms of how we might weigh in, just so we can connect the dots a little bit here?
Sure, it could be on a variety of different levels. Obviously, we would brief this all for you in closed session on a particular matter, given that there are all sorts of different strategic concerns. But certainly it could be by way of joinder or intervention into a lawsuit. It could be by way of an amicus filing that we've done many times. It could also be by the initiation of our own action. It really depends on what exactly is being challenged, how it's being challenged, and where it's being challenged. In some cases, for example, we may want to, if the need arises, bring our own lawsuit, but we would, of course, prefer to bring lawsuits, generally speaking, in our own California-based venues. But again, it's one of those things where if we see a need, we will raise it with you in closed session.
All right, thank you. Supervisor Lee, comments or questions, sir?
Thank you. One of the questions I have, of course, is relating to things that could affect our community and our residents. One of which, of course, on page 6 is the public charge rule.
Right.
We won on the district court. Ninth Circuit denied the motion to intervene. So at this point, they're trying to get cert from the Supreme Court. But until then, certainly there's no change. Therefore, the public charge rule that was proposed by last administration is absolutely not in effect. Am I correct?
I'm sorry, could you repeat that last part? It was a little hard to hear you.
Sure. So I'm just trying to confirm that the public charge rule that the last administration was trying to impose is not happening, right?
Yeah, it's gone for now. There are still some efforts by a few jurisdictions to revive the challenge that we had raised, but right now it's effectively dead.
Great, thank you. And as far as the new case, the asylum seeker issue there for Texas versus Biden, have we decided to send some amicus brief, or is it too early at this point?
I have not seen any decision internally in the county on that. That's something that we can certainly raise with you in the appropriate forum.
Great, thank you. And that's all the questions I have for now. Thank you.
Sure.
Thank you very much, Supervisor, and thank you again, Mr. Press. Let me just confirm with the clerk, we have no comments on item number 6.
We have no public speakers, Mr. Chair.
Thank you very much. That would take us to item number 7. And again, we turn to the Office of the County Executive, and in this case, relative to health policy and budget matters.
Hello, this is Danielle Christian again. I'd like to introduce Bert Margolin from the Margolin Group to provide this report.
Okay, thank you, Danielle. Good morning, Supervisor Samiti and Supervisor Lee. Much of the focus on the president's budget, which was released last Friday, was on the $6 trillion price tag, which was as high as it was because it not only included the baseline federal budget, but it also included the American Jobs Plan and the American Families Plan. So again, a lot of focus on the overall dollar amount. Let me briefly take you through, from a health policy perspective, the main takeaways in this new Biden budget. First involves the premium subsidy issue under the Affordable Care Act. You will recall that the American Rescue Plan passed earlier this year changed the subsidy structure under the Affordable Care Act in a manner that made the subsidies more readily available to more people. It also extended the open enrollment period. The Biden administration has estimated that 1 million people have been enrolled as a result of this change in both the subsidy and the open enrollment period, and that for 9 million current enrollees, there's been a $50 a month on average reduction in premium. Covered California, on the same change in federal law, estimated that Californians involved in Covered California will on average save $119 per month. So the American Rescue Plan, which instituted this policy, created this policy for a 2-year only period, limited time period. The Biden budget proposes that this reform be made permanent, that it become a permanent part of the Affordable Care Act. So that's issue number one. Second issue I want to highlight involves Title 10, the family planning program. The president's proposing $340 million in new funding and an almost 19% increase in the budget for Title 10. You will recall that Title 10 was under the so-called Title 10 gag rule under the previous administration. And as a consequence, large numbers of providers, nearly half the providers in the program, dropped out, including here in California. All the Planned Parenthood providers dropped out of the program. They didn't want to be subject to this gag rule, which would keep them from discussing various family planning services, including abortion. The budget is designed to restore capacity in that program and to allow providers to return to the program and even go beyond the prior level of service. The budget also features new investments in public health. The CDC has a proposed $1.6 billion increase in its budget authority. This includes $400 million in new funding for the public health workforce. So we're still not sure what this means. We're still not sure how much of this funding can be applied to local public health departments. It's somewhat vaguely worded, but it is a major new investment in the public health workforce, $400 million, and it's potentially going to involve new investments in county level resources. We'll have to wait and see for more detail to be developed. There's also a major increase in health research in the NIH, $9 billion of new money, including the creation of a new agency called the Advanced Research Projects Agency for Health, designed to sort of deal with innovations in health research, tackling cancer and Alzheimer's and other very deadly and chronic conditions that currently we haven't had we've had breakthroughs in treating them, but we haven't had the level of breakthrough that most of us would want. And again, Biden administration is comparing this to the cancer moonshot effort that Vice President Biden was engaged in, and he's trying to apply that same principle to a broader range of diseases through expanded NIH funding. Last item I'll just reference briefly is a $3.9 billion increase in SAMHSA funding. This is funding for a substance use disorder and other purposes. That's a $3.9 billion increase in a $11 billion program. So it's a very significant increase, and the county does benefit from receiving SAMHSA funding. So there will be a ripple effect on county funding, no doubt, should this new budget be approved. So those are the dollars that President Biden has put forward in his new budget. Not all of them, but some of the key healthcare initiatives that are actually funded in the budget. The president also in his budget makes reference to a number of healthcare goals. These are aspirations. They're not funded in the budget, so we can't really, so they're in one sense at a lower tier of priority because the president wasn't able to actually attach dollars to them, and you'll see why in a moment. But he basically said in his budget he wants the Congress to work on these issues, and he highlighted three that I'll now talk about briefly. And he wants the Congress to figure out a way to pay for them and to move these issues forward in some fashion. So here are the three big issues: lowering prescription drug costs, that's number one. Number two, creating a public option through the Affordable Care Act marketplaces. And number three, lowering the Medicare enrollment age. And I'll briefly describe what these three initiatives would entail. On prescription drug costs, the president does explicitly call for allowing Medicare, that is Health and Human Services, the federal government, to negotiate payments with the drug companies for a limited set of high-cost drugs. This is the initiative, the same initiative that Nancy Pelosi, the Speaker of the House, has supported. It's contained in a bill passed by the House at the end of last year. The president estimates that this reform would actually save about $500 billion over 10 years if it was approved. The House Democrats have been very anxious to get this approved because they believe this $500 billion can be used as a pay-for other healthcare initiatives. The challenge, though, and the reason why I think the president didn't put this in his budget in final form as his proposal is the margin in the House, as we've discussed in our past meeting, is very narrow. And recently, 10 House Democrats sent Speaker Pelosi a letter, and this is something I referenced at the last meeting, basically saying they wanted on drug pricing a bipartisan consensus approach, which is a coded way of saying not this approach, because this is not in any way, shape, or form bipartisan, and it's certainly not consensus because the drug industry vehemently opposes giving the federal government this negotiating authority. So this 10 Democrat group is a big issue. Nancy Pelosi has a big challenge here, but the president is saying he'd like to see this happen. The second issue is the public option. And as we've discussed in the past, there are many, many different ways to create a public option. So what the president basically said, he wants to see a public option. He wants the Congress to work on this. And what the Congress has done, actually, they did this last week, is they put out, and this is fairly unusual, a letter to the public asking for ideas on how a public option should be structured. And the letter came from the two key committee chairs, Senator Murray in the Senate and Congressman Pallone in the House. They chair the relevant jurisdictional committees, and their letter, joint letter, was basically a request for information to all stakeholders in the public option world, basically asking questions like what role should states play in creating a public option? How should a public option interact with Medicare and Medicaid? How should this program be structured in terms of eligibility and benefits? The deadline for receiving feedback is July 31, which makes action on a public option this year extremely unlikely. The committees won't even begin to get to work on this until the end of the summer or the fall after they receive this feedback. But again, the president doesn't want the public option, one of his 2020 campaign commitments, to fall by the wayside completely. So he's keeping the issue alive through this reference in his budget and this congressional process that's now been started. The last issue is lowering the Medicare eligibility age. The president explicitly in the budget calls for being lowered to 60 with the same benefits and structure as is currently the case for people above 65. But, and this is the key but, he says in the budget, he wants the financing to be separate from the existing Medicare trust fund. In other words, let's do this, but I'm not proposing that we use existing Medicare funding, which comes from payroll taxes, premiums, income tax, and Social Security benefits. He doesn't want any of that to be used for this purpose. He's saying, let's find a different way of paying for it. The phrase he uses is financing separate from the Medicare trust fund. And that is a big challenge for the Congress. So he's put the issue out there, but by not attaching any funding to it or any source of funding to it, he's basically keeping the issue alive, but making action on it this year, again, very, very unlikely. So these items, Mr. Chairman, are the major items contained in the president's budget. Gives you some sense of the landscape that the Congress and the administration will be dealing with. I'd be more than happy to respond to any questions that either you or Supervisor Lee may have.
Thank you very much, Mr. Margol. And let me just ask the clerk first if we have speakers on this item.
We do have one request to speak, Mr. Chair.
And let's go ahead and accommodate that before we turn to Supervisor Lee and myself for comments and questions.
Okay.
2 minutes, please.
Thank you. One moment while we get the timer set up. Our next speaker is B. Beekman. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, Blair Beekman here. For this item, it speaks to, the U.S. federal budget and American Rescue Plan Act ideas. I hope I can not just talk about, the importance of health and human services ideas that you're working on, healthcare issues, basically, but issues of just simply ask flat out. I've been working the past month or so. I've been mentioning the idea, do we need to be preparing for a possible upcoming large earthquake in the Bay Area for the year 2023? And if I put that out there now, it makes it easier for you guys to make choices and consider what exactly you have to work towards. I'm trying to make a process open and understandable, and so we can all feel more comfortable to talk about it. We are going to have to address natural disasters like wildfires, sea level rise, climate change issues. It has to be a part of the mix of how we are going to be asking for budget dollars and working budget plans in the next couple years. And to add the idea of a possible earthquake, how will that be included in funding ideas? How do we prepare ourselves? How to work towards subsidy planning and all of its issues? And I just wanted to make light of that at this time and to note it. And I hope you can you have made some good strides how natural disaster preparedness at this time can be an open subject matter, and I thank you for that. I hope we continue those good efforts and it becomes an easy subject to talk about as a community. Thank you.
And that concludes our public speakers.
Thank you very much. And let me go to Supervisor Lee and see if he has comments or questions before I proffer my own. Supervisor?
Thank you. Mr. McGrillen, thank you for the good report as always. 6 trillion certainly sounds like a lot of money. They used to be saying that a million here, a million there is all money. Now we're a trillion here and trillion there. The excitement I think you mentioned is the public health, $400 million coming through. There's not a whole lot of detail with it. I'm sure you'll be monitoring closely for us down the road as soon as we get them, because obviously they come straight to the key mission of our county here, and that's certainly something that we could use that type of investment. The $9 billion on the new organization you're talking about, so that's actually related to public health research, right? At the end of the day, isn't it?
Yes, that's correct.
Okay, yeah, that's certainly also exciting. And the one part I think I missed your discussions regarding, you say the SAMHSA funding after that. Could
Yes.
you elaborate that a little bit more? Sorry.
This is the program that funds substance use disorder treatment, and it comes to the state and counties through grants, block grants, and this substantial increase in investment suggests that there'll be more money for substance use disorder treatment, for drug treatment in the county. We don't know how much more. We don't know how it's going to be structured exactly. And bear in mind, the other thing I probably should have said, and I will say now, president's budgets are just a starting point, and the Congress can and does frequently make major changes in what the president proposes. But the president's basically saying that substance use disorder needs substantial new investment, and this is a massive increase in investment.
And I cannot agree more. Thank you. Now, the other issue you talked about is regarding the bill to reduce the prescription drug costs. Are you talking about HR3?
Well, I don't have the bill number in front of me, but the president, again, in this case, wasn't endorsing a bill. He was endorsing a concept. And if HR3 was in fact the bill that the House passed on prescription drug costs in December, if that's the same bill, then we're talking about the same issue. Basically, it's the proposal that would give Health and Human Services, the federal government, the ability to directly negotiate with pharmaceutical companies for the price of high-cost drugs, to use the big market power of Medicare to basically fight for a better price. That's currently prohibited by law. It's not allowed. They can't negotiate using the market power of the federal government. The pharmaceutical industry is adamantly opposed to that. The House Democrats last year passed a bill which would give the federal government that authority. The Senate is not yet in a position to take that bill up. The votes aren't there. Now we have this dissenting position by 10 House Democrats, who essentially said in a recent letter to the Speaker, they don't want to see this approach pursued, even though some of them voted for this exact proposal last year. They've changed their mind since. And so even though the political environment is difficult for this proposal, the president is basically weighing in now in his budget and saying, listen, I know it's going to be tough and I'm not proposing you act on it immediately, but I want the federal government to have this authority. I'm with the Speaker of the House.
Yes, that's right. Yes, the Medicare Part D program on the negotiation of the drugs in HR3. So I believe that's maybe the new law for this session that's being proposed by Congressman Peters. So thanks for bringing that up to us. One other piece of legislation I would like to ask to check in with you is HR 831, which talks about amending the Public Health Service Act to encourage the rapid development of certain public health data standards and some type of grants. And I would like to see if this is something that is moving forward in the next report. I'll appreciate that.
Yes, we will definitely do that for you.
Okay. Another legislation that talks about maternal health more accessible to low-income Americans, which are HR 4995 and HR 4996.
Okay.
Let's see. There's the Black Maternal Health Omnibus Act that was 6142. I thought we discussed that previously in some of our other committee, but I just want to check to see if that one's moving forward as well.
Okay.
And a couple more to look at. Oh, that's right. Yeah, the Opioid Patients Right to Know Act of 2021, which is HR 1185.
Okay.
Okay. And along with that, there's HR 2366 regarding addiction overdose by fentanyl and other opioids.
Okay.
And that's related. And the last couple that I have is, oh yes, this one regarding the tax credit for healthcare premium, HR 369.
Okay.
Okay, reducing the cost of healthcare premiums. And last one is HR 1123, which is the Veteran Suicide Prevention Act.
All right. We will evaluate all of those bills and provide you with an update either at the next meeting, if that's your preference, or even before the next meeting, if that's more to your liking.
I mean, if you could get it to us earlier, I certainly appreciate it, but I think it would be great to have a quick verbal report in the next meeting so the public is to hear it as well. Thank you.
All right. We'll be prepared for the next meeting to make sure that you and the public have updates on all those issues.
Thank you, Mr. McGowan.
Happy to do it.
Supervisor Lee, anything additional?
I think I have enough for this morning so far. Thank you.
That was a lot. Thank you, Mr. Margolin and Supervisor Lee. I don't want to put anybody on the spot, but it occurs to me we will be meeting in 3 or 4 weeks as the Health and Hospital Committee. Mr. Margolin, is that too soon to ask you for an update on the issues that Supervisor Lee referenced, or would that work for you?
That works for me. That's not a problem at all. I'll make that-
Supervisor Lee, I thought that might accommodate your desire to have that additional information sooner rather than later, if that works for you as well, sir.
That's perfect. Thank you so much, Chair.
Thank you. And then, Mr. Margolin, I'm going to ask you to assess, and I know this is always fraught for you in particular, but ask you to assess the probabilities here, some of these things coming to fruition, because much of this, of course, is to be expected in the way of opening positions, if you will, efforts to raise issues, build awareness and support. But I'm looking at the three items that you mentioned: the drug pricing, the public option, and Medicare age reduction to 60. And I'm going to ask you, I know this is unfair, but I do it to you every time, as you know, so you've gotten accustomed to it. If you had $5 to bet by the end of 2022, when this Congress is no longer in session, are we likely to see the drug pricing action on Medicare in your best judgment?
It's not likely, but it's not impossible, because the Speaker and the House leadership are very committed to it. And some of this, of course, relates to whether or not the filibuster rule is amended in the Senate. So all these issues to some extent relate to that, because the House is challenging enough with a narrow margin. But if the Senate rules stay the same, odds are much smaller. If the Senate rules get changed, odds increase. So again, it's uphill.
And how about the public option? Same response or different?
A little different, because the pharmaceutical issue involves the opposition of a very powerful industry that's very mobilized. Public option is, again, there's a lot of logic to having a public option. There's a way to structure it so that it's at the discretion of individual states, and that there's flexibility, and that it isn't imposed on every state, and states that want to pursue it can pursue it. So there's a way to structure a public option that actually could be, even though it strengthens the ACA and there's Republican resistance to doing anything that makes the ACA stronger, depending upon the political environment, and again, the filibuster rule is a big factor. That's not out of the question for 2022.
And I'm going to come back to that in a minute. And what are the chances on dropping Medicare to 60?
Well, the problem there is the cost. It's a very big cost. So, and again, it may relate to things like the pharmaceutical issue. There's $500 billion in savings from pharmaceutical. If that suddenly has more life to it than currently we can give it, maybe the savings there can be applied to dropping the Medicare age. And that's the kind of linkage that might make a pharmaceutical reform more likely. But again, because the president didn't put it in with his own dollars attached to it for a reason. It's very costly. He's already got in this $6 trillion package a number of very costly items. So the one reason why I wouldn't rule it out, and all these ideas have some chance of action, is lowering that Medicare age. If you poll the issue, if you ask people, what do you think of that? It's a very popular position. And it's not Medicare for all. It's a modest adjustment in the program. And if they can figure out a way to pay for it, which is the big challenge, and depending upon where President Biden sits politically in 2022, there's a chance this issue could have some life to it.
And I'm going to come back to that one as well in a moment. And then you referenced earlier in your remarks as a somewhat standalone item, and please correct me if I misspeak here, but I would characterize it as a greater subsidy for the Affordable Care Act and through the exchanges as a 2-year item at present, but an initiative now to make that permanent. Did I characterize it correctly? Let's start there. And it's okay to just correct me in front of the entire committee. It's all good, Mr. Margolin.
No, it's that's correct. It's currently a 2-year initiative, and the president's budget suggests that it should be made permanent.
And any thoughts about the potential likelihood of that happening over the course of the next couple of years?
I think it's very high that
Okay.
it will happen because I think it's popular. And I think that if the president, it's popular, it was approved in the last package. Again, it depends upon whether the president has to use reconciliation to get this package through. And well, in fact, he will use reconciliation for, this is a budget item. So, you know, it's very unlikely that this drops out. I think it's likely, this is likely to happen.
And is part of that the simple politics of folks not wanting to be in the position of, quote, taking something away from people that they already have?
Yes, it's already been given to people. So this will be characterized if Republicans work to exclude it as a takeaway. You're absolutely right.
Got it. Okay. Then going back to the three other initiatives that we discussed, on the Medicare age reduction to 60, you highlighted that high cost is a clear challenge. I'm curious. You know, we spend a lot of time, as you know, in Santa Clara County, focusing on, you know, what percentage of our population has an insurance product of some kind. Could be employer provided, it could be Medicare, it could be Medicaid, Medi-Cal, it could be some other program. And then, of course, we have, you know, our best estimate is probably 5% who still don't have insurance. And then the question, of course, is, can we provide them with health care, if not health insurance? So the reason I went through that long riff, Mr. McGowan, is I'm curious what percentage of folks in that 60 to 65% don't have insurance. You've indicated it is deemed to be expensive, which would suggest to me that it must be a relatively large number of folks. And is that because these are folks who have left the workforce and are no longer eligible for employer based insurance? What's the dynamic there? I'm trying to figure out who these folks are and what their circumstances are.
Right. You're asking good questions here. I don't have an analysis or breakdown yet of that population. It's expensive because, you know, Medicare is inherently an expensive program. Also, I'm speculating here that because we're dealing with people over the age of 60, their need for health care is more significant than a 40-year-old or a 30-year-old. So it's an older population with more healthcare needs. And again, this is not necessarily, this would allow employers to you know, people can move to Medicare. They could be, you know, and move out of the private insurance market. So this wouldn't necessarily be a pure question of people who are uninsured getting coverage, although it would include a significant population. It would also include shifting coverage from the private sector into the Medicare program. So I haven't seen yet a breakdown or analysis, but I'm happy, Mr. Chair, to look into this further, and maybe at the next Health and Hospital Committee meeting, I can add this to my list of items and try to give you a little more insight into what this cohort is like.
I think that would be helpful, and I'm just going to ask the staff from my office who is sitting in on this meeting to make sure we get these follow-ups agendized in some formal way, so we have our to-do list squarely in front of us. Mr. Margolin, when you talked about shifting, did I infer correctly? I know I inferred it, but I don't know if it was correctly, that if the Medicare age was dropped down to 60, then the anticipation or the expectation would be that some employers who do provide insurance would say, well, we're going to provide insurance, but it's only for our employees up to the age of 60?
That's entirely possible, yes.
Okay. All right. Well, I would appreciate having some additional information on this piece of the proposal. And related to that, and I think you'll see where I'm going here, the public option discussion, you mentioned...
Mr. Chair, can I just make one correction here on
Please.
The last comment that I made? Yeah, when I say it's possible, I don't think they would propose that employers would be absolved of their obligation to provide insurance coverage. It would be more a question, I think, of individuals choosing to take Medicare, preferring Medicare to the private coverage. I don't think.
Okay. Thank you. No, that's a helpful clarification. Thank you. Yes, I would like to discuss that a little bit more and get a better understanding of the possibilities there and how such a thing would or wouldn't play out. And then on the public option, I was intrigued by the notion of the public option being a state by state possibility, as we've seen something similar, I assume, to what we've seen with the state by state option on Medicaid expansion.
Yes, yes.
And take us back to the beginning, and I appreciate Supervisor Lee's forbearance here on my question here. Take us back to the beginning. So we have an Affordable Care Act. It did not have a public option in it, even though that was something that people discussed at the time of its adoption. What would a public option look like? And just sort of generically speaking, and then how does that roll out if it's a state by state proposition?
Well, generically speaking, we're talking about a government-run insurance product that would be available in the marketplace. So in covered California, you'd have all the plans you currently have, plus you'd have something designated as the public option. Again, we have here in Santa Clara County, obviously there is a local plan that is a quasi-governmental offering, and depending upon how public option is defined, these local initiative health plans under Medicaid could be considered compliant with the public option requirement. Again, this goes to what the federal rules and requirements are, but the idea would be to create a plan that has government sponsorship, and the reason why these two committees in Congress are putting out the request for information is there are many different ways to structure this. You could make the public option Medicare. You could say we're as a state, we want to have Medicare available to the residents of our state. So rather than having the plan be a private plan that's government structured and that's government regulated, we want to actually have Medicare be the public option. And we want to have.
Excuse the interruption, Mr. Margolin. And if that were the approach, people would buy insurance, quote unquote, but the insurance they bought would be Medicare?
Yes, or a Medicare-like product. I mean,
and the hope and expectation would be that it would be less expensive and a better value than commercially available plans. Is that the thinking?
The thinking would be less expensive, and also there's a competitive dynamic here that if the government is putting out sort of a model product that has the benefit structure and the accessibility that the government thinks is appropriate, that the other plans in the exchange, in order to keep people from choosing the public option, would work to make their plans better, so that you end up with competitive pressure for a better product all across the board. But one of the questions these two committees are asking is, how does this public option interact with Medicare and Medicaid? They're not suggesting they know the answer to that. So there's just many different ways of structuring it. And you also have, so there's lots of options here. It could be a national program where every state has to provide a public option. It's probably more likely to be along the lines of what you suggested, Mr. Chair. When Medicaid expansion was done, it became a state by state. Well, actually, it was initially, until the court intervened, a national program. Then the court said it had to be state by state option. So it wasn't really the federal government's preference that it be state by state optional. That was the court decision, Supreme Court decision, that created that scenario. So, but it's possible that could be the model that the Biden administration uses, that they create carrots for states to create public options, give them parameters under which a public option can be created in a way of defining it, but they don't require it. That's an option. But again, you can see that the thinking on this is not very far advanced yet in Washington. And you've literally got this open inquiry period where the two key committees are saying, listen, we don't know quite what we're going to do yet. Give us your ideas.
All right. Thank you very much. That was very helpful for me in understanding how such a thing might be rolled out on a state by state level. And are there reasons why, I'm sure there are, what are the reasons, if there are any, why some states might choose not to participate other than an ideological antipathy to a government healthcare program?
Well, I think the antipathy to a government healthcare program is a big factor. And you've also got the private insurance industry that's not, for the most part, happy about the public option concept. They're providing you've got two kinds of states. You've got states that are implementing the Affordable Care Act with private plans signed up in their marketplaces, in their exchanges. And those private plans are going to say, wait a second, we're already doing this work. We've invested nearly a decade in creating this network of providers. We don't need a public option. We're good enough. And that's one category of resistance. And you've got the states that are not yet, the 11, 12 states that are not yet in the Medicaid expansion program, who don't ideologically want to be part of this. They're resisting the exchanges. They're going to resist the public option just as strongly.
All right, thank you very much. And Supervisor Lee, I have no further comments or questions on this item number 7. Is it okay with you if we move on to item number 8, sir?
Yes, actually, I do have one quick follow-up question,
Please.
if I might share, with Ms. Margolin. Regarding the public option state by state, correct me if I'm wrong, I heard something like Hawaii already have a public option for its residents. Is that true? Or I just heard
Yes,
that
sir.
there are already states that has adopted it, and
Yes.
it's actually working quite well. I don't know how many states, if you know offhand. Sorry to put you on the spot, but have you?
Well, that's all right. I think there are two states. I think Hawaii and Washington State are the two states that have declared that they have some form of public option. And again, they aren't the same, and they're defined differently in each state. Washington State's had some challenges, as I understand it. Hawaii is working better, and I'm happy to provide more information about that at a meeting if you'd like to learn
Oh
more.
yeah, absolutely. I've always said to many people, I am not at all about not invented here. As a matter of fact, I'm really big about copying good ideas. So if there are other successful state examples that we could learn from, I certainly do like to see what they are, and hopefully and learn from them. Yeah, thank you very much.
I'll include that in my next report.
Thank you.
All
Thank
right.
you,
Thank you very much, Mr. Margolin. Thank you, Supervisor Lee. I think that takes us to item number 8, which is report from the county executive with regard to eligible expenditures under the American Rescue Plan Act of 2021.
Thank you, Chairperson Simitian. This is Danielle Christian again. As you all know, the American Rescue Plan Act was signed into law on March 11th. One component of that was the establishment of the Coronavirus State and Local Fiscal Recovery Fund in the amount of $362 billion. The county's allocation from the Recovery Fund is approximately $374.5 million in one-time funds. This is direct aid that's being provided to local jurisdictions, and there's a component for the state as well. Deputy County Executive Martha Wapinski is our county's coordinator for all countywide COVID-19 funding, and she will provide the report on this agenda item specific to the local recovery fund.
Thank you, Danielle.
Thank you, Ms. Wapinski. Go right ahead.
Sure. The American Rescue Plan, which I'll call ARP throughout my comments, does provide much needed infusion of resources to help the county address the impacts of the pandemic, but also set the foundation for a strong and equitable local recovery. Before I talk about the eligible uses, it's important to point out that with regard to the ARP regulations, we have an interim final rule, but we continue to await the final rule. And I just want to make sure that that's noted here. On May 10th of this year, the U.S. Department of the Treasury announced the interim final rule to implement the funds that Danielle just mentioned. The comment period for that interim final rule closes on July 9th of this year. And the publishing date for that final rule and any possible changes in the rules and regulations is not known at this time. But we're hopeful that we'll know soon after July 9th, since the first extensive amount of reporting is due back to the U.S. Treasury in August. As Danielle mentioned, the county's allocation for ARP is $374.5 million in one-time funds, and the county is paid directly in 2 tranches. We got the first tranche of 187.2 million on May 19th, and the next tranche is expected in May of 2022. In addition to reimbursement from FEMA, we're expecting increased federal revenues received by departments through other federal and state allocations due to the 1.9 trillion ARP funding package. Should be noted that ARP is for costs incurred between March 3rd of 2021 and December 31st of 2024, with a few exceptions. Some of the resources have been included in the current FY 2021 budget based on the anticipation of this new federal funding for vaccination operations and other direct pandemic response. Now, getting to the interim, the eligible uses, the interim final rule outlines 4 global uses, all tied back to the consequences of the COVID-19 pandemic. First, strong, urgent COVID-19 response efforts. Second, replace lost public sector revenue. Third, support immediate economic stabilization. And fourth, address systemic public health and economic challenges. The interim final rule includes an equity framework, including health disparities, housing, education, and healthy childhood. So let me go down a list of some examples of eligible uses. This is not an exhaustive list, but it gives you an idea of the uses available under ARP. First is COVID-19 mitigation and containment, as well as medical expenses. There's assistance to workers and their families. It also includes food, housing, cash, and other assistance to households. The funds are also eligible to speed the recovery of impacted businesses and industries with loans, grants, and technical assistance. Eligible uses also include services for the homeless and affordable housing development. For children, it includes expanding early learning services, childcare, resources for high poverty school districts, tutoring, and after school programs. It also includes new or enhanced behavioral health care services, which were spotlighted by this pandemic, as well as broadband, water, and sewer infrastructure. Those are just some examples, as I pointed out. I do want to point out what the restrictions are in the interim final rule. We cannot make extraordinary payments into pension funds. We can't use it to offset a reduction in net tax revenue. We can't use it to fund existing debt service, nor can we use it for legal settlements, nor rainy day reserves, because this is really meant to address public health and economic challenges. So until we have the restrictions and requirements in ARP's final rule, we're not putting forward a plan yet that allocates all of these potential resources. But we do know that a substantial portion of these funds will be directed toward the hospital system and other health needs. I also want to highlight that there's an administrative burden of accounting for, tracking, reporting these expenditures. It will be substantial and it will take years. And so will be incorporated into our plan for how to utilize these revenues when we come back to the board. And depending on when this final rule is complete, we may be able to bring a plan to the board in August, but again, it depends when the final rule is done. And with that, I'll go ahead and take questions.
Thank you so much. Let me first check with the clerk to see if we have speakers on this item.
We do not, Mr. Chair.
All right, then I'll turn first to my colleague, Supervisor Otto Lee. Supervisor?
Thank you, Ms. Popinski, on your update. This is a lot of information. Again, a lot of things are still happening and changing. So all we have really is just an interim ruling that we're getting. So before we get the final amount, the one thing you did mention, of course, is the good news, is that the first tranche, as you say, the 187.2 million, we've already received it sometime in mid-May, correct?
That's correct.
Good. And we are sitting on it, earning interest, I hope.
It was placed in a special fund.
Okay. The one issue that I'm very concerned about, of course, is also the spending deadline to make sure that there's no way that we leave any money, quote unquote, on the table. Is there a date already certain of when the funds has to be expended by?
Yes, that's a good question. So these are for expenses that are incurred after March 3rd of this year, and the funds need to be obligated by December 31st of 2024. So for instance, if you need to purchase a piece of equipment, let's say, you need to obligate those funds by December 31st of 2024, but you need to actually perform on that, i.e. buy the piece of equipment by December 31st, 2026.
So we just have to make sure that we have obligated it and then paid within 2 years.
Correct, by December 31st, 2024, correct.
Okay, good. All right, and I know there'll be more reports as we get more and more information down the road. So I guess I'll just I'll leave it at that for now. Thank you.
Thank you, Supervisor Lee and Ms. Lipinski. I just want to tease out one issue here. I understand, as you shared with us today, and I think previously, that that the funds are for specific purposes, and that as a matter of law, we are obliged to spend the funds for those purposes. That being said, money is a fungible thing, and if we have these federal dollars to spend on these various expenditures, these various costs, that clearly has the benefit of freeing up other funding sources, including our general fund, which would otherwise necessarily have been used for expenses that we were expecting to incur. Yes?
You're correct in that part of my job is to make sure we spend the most from the most appropriate bucket for whatever funding source, be it housing, childcare, etc. And so my job would be looking at all the various federal, state funds to make sure we're spending appropriately.
Yeah, I guess what I'm trying to say is, and feel free to clarify, correct if need be, but in some jurisdictions, they might have to create some new programs in order to identify a set of expenditures sufficient to meet their allocation. I can't imagine what that must be like, but I'm guessing it's theoretically possible. But it seems to me in our case, given the very aggressive posture that our county has taken and continues to take in addressing these needs, I don't have much worry that we're not going to have already in the works plenty of efforts that could use this funding. Do you?
From the public discussions I've been listening to, it seems like we'll have plenty of uses for this funding.
Yeah, I think, I think, as I say, I think it undeniably releases some pressure on other parts of our budget, not because we're going to misuse the funds or misdirect the funds in any way, but simply because these are expenditures we knew we were going to have to make. We anticipated we would have to make them, and we were wondering how we were going to pay for it. Fortunately, now there's a good answer to that question. Doesn't mean that we're particularly robust or rosy, but I just, as I say, I do feel like it has the benefit of reducing pressure in other parts of the budget. All right. Anything else you want to share with us today?
No, thank you.
All right. Supervisor Lee, anything else on this item? I think we've got it covered.
Yes, I think so. And Ms. Lipinski, thank you so much. Next week, we have a special meeting for FGOC on June 9th. I would like to see if you could give us a little more details of what, hopefully more fleshed out in the presentation on these funds now that the information is coming slowly. But I certainly appreciate whatever you could provide at that point, and we could probably send you a little bit more detailed on a separate email. Yeah, thank you.
Absolutely.
All right. With that request, we will conclude that, and without objection. And forgive me, Mr. Chair, excuse me, Mr. Clerk, I don't think I indicated that on prior items, we had simply received the report without objection. And thank you for the record. All right, Supervisor Lee, I think that completes all of our business today. Without objection and hearing none, we will simply adjourn to our next meeting, currently scheduled for Wednesday, August the 4th, but with the understanding that it may be rescheduled depending on availability as we come out of the July recess. All right.
Thank you.
Thank you to the clerk, thank you to the public, and thank you to all who participated today. Without objection, we are adjourned.
Recording stopped.